Hello and welcome to another episode of Local Expert Interviews. My name's Michael Grady. Today we're going to be speaking with Dr. Kevin Boyd of Dentistry for Children and Families in Chicago, Illinois. For nearly 25 years, Dr. Boyd has been providing comprehensive pediatric dental care in the Lincoln Park neighborhood of Chicago. With the addition of child-focused general dentists, he is able to offer these comprehensive services to parents as well. Welcome, Dr. Boyd.
Good to be here, Michael.
Dr. Boyd, please tell our viewers a little bit about yourself and your practice in Chicago.
Well, I can tell you about myself. I am currently getting ready to go to graduate school. I'm 59 years old and still not fully grown up. I want to go back to college. I'm interested in biological anthropology as it applies to dental health. Believe it or not, they don't teach dentists much about our ancestors and what their jaws and teeth looked like. And when I learned some things about the shape of the jaw and how teeth used to be cavity-free and nobody needed braces, nobody had impacted wisdom teeth until roughly about 300 years ago, I thought I better learn more about this, because that suggests that genetically pretty much every kid, and I'm a kid's dentist, has the potential to be cavity-free and to really grow up not necessarily needing braces. But that requires that you start doing certain things a little differently than the way I was taught in dental school. And it's resulted in some pretty amazing scientific findings and has led to some major research projects that we are doing at Northeastern Illinois University here in Chicago, where I'm preparing to enter a graduate program in anthropology. They don't have a grad program at Northeastern, so they're preparing me to go to a different place where they do have a master's or a PhD. Also at Lurie Children's Hospital, we're conducting a trial that really is predicated on some theoretical things that I learned in my anthropology training, and we're helping little kids' jaws grow bigger and making it easier for them to breathe and sleep better. So I think anything else I'd tell you is just kind of like any other dentist, which was, I don't know, there's nothing wrong with being like any other dentist. It's a great profession, but this is a little different.
Well, let me say, be the first to say, good luck with grad school. I know that my undergraduate was pretty difficult, so I know that your postgraduate work is going to be that much even harder. So today, what I'd like to talk to you about is something that I know that you've been a pioneer in, is pediatric sleep apnea. Could you tell our viewers what exactly is pediatric sleep apnea?
Well, I'm a pioneer in sleep apnea, but not because I think it's a good thing. We try to prevent it and make it go away early in life without having to do surgery or give medications. The whole reason that kids have trouble in sleep apnea just means that during sleep, children will hold their breath, and then they will gasp for air, and this is called obstructive sleep apnea. There's another type of apnea called central apnea, which is different. But obstructive sleep apnea, what is obstructing the airway? And an airway can be obstructed in the nose, in the sinuses, the back of the throat. Those are the main places. And what we have found is if we can widen the airway in the back of the throat where the adenoids are, it's called the nasopharynx. We do that by helping the front of the face come forward. And when that does that, it pulls the soft palate, which hangs off the roof of your mouth, and it's right across from where the adenoids are. Well, if a kid's soft palate is close to where the adenoids are to begin with, the adenoids don't have to get very swollen to cause an obstruction. So what we're suggesting, and we have now several patients who have shown on x-rays and sleep studies, that after we bring the front of the face and the palate forward, it widens that airway. Even if the adenoids stay enlarged, they start breathing better. And this will hopefully, in a lot of these kids, lead to their adenoids shrinking to normal. And adenoids are just lymph tissue. They fight infection. If a child is able to breathe through their nose all the time, habitually, while they're awake and asleep, there's no reason for the tonsils to get big in the adenoids. That's hypothetical. We haven't proved that yet. We still have a lot of work to do, but we're getting some really encouraging preliminary results on our study patients. So that is really the biggest thing. The other thing is when a child can't breathe through their nose, especially at night, but during the day as well, they'll breathe through their mouth, and they will start to tilt their spinal cord to try to make the bottom lower part of their throat wider. And we find that when we widen these kids' jaws and pull the palate forward, that their spines go from being curved to being straight again, like they've been to charm school and walked with a book on their head. They get beautiful posture. They breathe better. They stop sweating in their sleep. They stop snoring. They stop grinding their teeth. There's studies that suggest they grow better. We even had a mother today that reports that her child is not only sleeping better, but doing better in school. So we have to prove all this with studying lots of kids. And we're going to be collaborating with some other major institutions on this. And it's going to be leading to policy change. There's already significant interest from major healthcare organizations to help change policies based upon our research. So
that is really incredible information about pediatric sleep apnea that I think a lot of people might not understand that you would get from a dentist. So how do you see your role as a pediatric dentist changing?
Well, again, as a pediatric dentist, we perform services in accordance with the standards of care that have been set by scientific committees at the American Academy of Pediatric Dentists, upon which I have been a consultant, mainly on nutrition, and in accordance with standards set by the American Board. I'm a board-certified pediatric dentist. And one of our primary charges, one of our primary policy statements is that every child should have access to care by the age of 1 and establish a dental home. Have a dentist that understands children, whether they're a pediatric dentist or a general dentist that is focused on kids, by the age of 1 to assure, A, that they are free from pain, and B, that they have adequate function of their jaws and teeth. Well, with what we have found is that an additional thing that we hope to add to these standards is to assure that a child has architecture of their palates, faces, and jaws is conducive to healthy breathing through the nose at night. So this is something that we hope will impact the American Academy of Pediatric Dentistry's standards of care, is that in addition to freedom from pain and adequate function and several other factors, a primary objective of when we assess a child's health in early life is if they are free from things that might render them susceptible to apnea when they're older. And that is if their palates, the roof of their mouths are narrow, if their jaws are positioned too far back, if their mouths are open, they can't close their lips. There are several things that we need to teach dentists and parents and pediatricians, and this has the potential to really impact healthcare in America and worldwide, just by the work that we're doing at Children's. Very exciting stuff.
It sounds exciting, and it sounds like pediatric sleep apnea is a fairly wide problem. So my question for you is, what are you doing to raise awareness about pediatric obstructive sleep apnea?
Well, I've published some articles. I collaborate with other people who published articles. Karen Bonnick is a researcher at Einstein Medical Center at Montefiore in New York. She's collaborating with Michael Gelb at New York University. I serve on a board with Michael Gelb called the American Association of Physiological and Medical Dentistry, AAPMD. And Dr. Bonnick has made a link between attention deficit disorder, impaired neurocognitive issues like, not just attention, but maybe even ability, IQ, is that early in life, if a child can't breathe through their nose at night and they snore, this could lead to behavioral and other neurocognitive deficits down the road. Well, we've made a connection to snoring and apnea in the shape of the jaw and face. So now Dr. Bonnick and Dr. Gelb and I are collaborating to do a large study to connect all three of these. In essence, hypothetically, what this is saying is at age 1, 2, or 3, or 4, by the shape of telling parents, just by the shape of the jaw and the face and the way they curve their cervical spine, a child might be susceptible to getting apnea, which could be related to neurocognitive brain deficits. Just by the, pediatric dentists are ideally positioned to help identify these kids who are at risk and to start working collaboratively with ear, nose, and throat doctors, pediatricians, sleep medicine physicians, speech pathologists, teachers, parents. It's a really big deal. And it's OB-GYNs. I mean, we're even picking some of these signs up on 3-dimensional ultrasounds of babies that aren't even born yet. And we're following them after they're born. And a few of the kids that it's not a very large sample now, but some of them are almost 2 years old, and they're showing signs of sleep apnea. And we saw it in utero. So, getting these kids identified early in life, and in many cases, and I'm actually qualified and experienced in treating, and I get referred kids that are under the age of 3 from Lurie Children's Hospital that have sleep problems identified in overnight sleep studies, and we're expanding their palates and bringing their faces forward and their soft palates forward, and the improvements are pretty significant so far. It's still early. We've got a lot of work to do to make this really scientifically proven with well-designed studies, large patient population samples from multiple institutions, but we're doing that. The preliminary data is so impressive that we're actually designing a couple of very important studies and applying for NIH funds for this, National Institute of Health.
Dr. Boyd, let me ask you, as parents, teachers, child caregivers, what are the signs that we should be looking for in children that may suggest that they have a sleep apnea assessment that's needed?
Well, first of all, if a parent can, I ask every parent a whole list of questions, every new patient that comes to my office, and these questions really have nothing to do with cavities and gum disease and the traditional things. I ask those questions as well. We call it a thorough medical history and then a thorough dental health history. But I ask questions, what time does your child go to bed at night? I mean, a regular bedtime is huge for assessing sleep quality, not quantity, but quality. We want to know how long a child sleeps, but we want to know how well a child sleeps. You have to have both hitting on all cylinders. So a regular bedtime is very important. Falling asleep within 15 or 20 minutes of going to bed is important. That's called normal sleep latency. Sleeping with the mouth closed and no noisy breathing, that's important. Staying still while they sleep, minimal movement, but kind of staying in one place all night, maybe turning once or twice, but not kicking the sheets off and rotating, and restless sleep is not good. Quiet sleep in terms of not talking, not snoring, not screaming or night terrors. Those are all signs of bad sleep and that the child is trying to get more oxygen to the brain without actually waking up. Wetting the bed is bedwetting, or getting up to go to the bathroom. That's the same thing. We call that nocturnal enuresis. That's the brain trying to wake the kid up or get closer to being awake so they can get more air. not sleeping in contorted positions, like with the neck twisted. That's an attempt by the brain to subconsciously open up the airway because the brain's not getting enough oxygen. A little baby sleeping on its belly with its butt up in the air, that's a sign that the child is trying to get more air. I'm sorry, I just got a big old thing on my screen. Okay, it went away. Do you want to start over, or can you? I don't know what to tell you. You want to try to pick up where that left off?
Yeah. Yeah, because I can cut this out. All right, so Dr. Boyd,
okay. Yeah.
As parents, teachers, and child caregivers, etc., what signs should we be looking for in children that may suggest they have a sleep apnea assessment need?
There are known what we call risk factors for sleep apnea, and that's usually picked up on a sleep test. It's called a polysomnogram overnight in the hospital. You can't do home sleep studies on children. You can on adults. They have to actually go to a certified pediatric sleep center. There aren't very many of them. It's kind of a problem. But some of the risk factors that we know is grinding of the teeth at night. It's called bruxism. That's a child's attempt to open up the airway by shifting the jaw back and forth and forward. That makes it wider and they can get more air in that way. Snoring is a risk factor. Bedwetting is a risk factor, or getting up to go to the bathroom more than once or twice during the night. It's called nocturnal enuresis. That's an attempt to get children out of deep, slow wave sleep where they don't get as much oxygen to closer to being awake. In stage 1 and 2 sleep, we call it non-REM sleep, and that they get more oxygen when they're in higher levels of sleep or awake. Kicking the sheets, that's the legs are trying to move the blood up to the heart to get more oxygen to the brain. Falling out of bed, sleepwalking, sleep talking, night terrors, dark circles under the eyes, those are all things that are risk factors. And there's certain things in the jaw. If a child has constantly got their mouth open, can't close it, their teeth stick out, their jaws, one of their jaws or both of their jaws are too far back, or the upper jaw looks too far forward, that's an indication, a risk indicator of sleep apnea. The roof of the mouth, if it's deep and narrow, the roof of the mouth that's called the hard palate. That's a risk factor. So and these are all evidence-based, we call it. There's scientific studies to support that these are things that should be identified as early in life as possible and should be corrected if there's a qualified dentist. And some of these things can really be fixed just by expanding with orthodontic expanders under the age of 5. It's not really for orthodontic purposes, although it does render the jaws more capable of supporting all the teeth in better position. But really what it's doing is it's making room for the tongue early in life to be up and forward off the back of the throat. And that's what's conducive to habitual nose breathing. And nose breathing, nasally inspired air is much cleaner. It's humidified, it's warmed, it's moistened, and you also have a chemical in your sinuses called nitrogen oxide. Nitrogen oxide, not nitrous oxide, that's laughing gas. But this is a chemical that every time you breathe through your nose, like right now, Michael, close your lips and take a snort of room air there. You just dosed yourself with nitrogen oxide.
Really?
Powerful antioxidant, powerful antimicrobial, kills fungus in the air, kills dust mites, kills bacteria, kills mold, and it widens the blood vessels at the end of the respiratory tree. They're called alveoli in the lungs. That's where the exchange occurs. Oxygen goes from the lungs into the bloodstream to the heart to the brain. Okay, so you get better air. It's health food air. Or when you breathe air through the mouth, your mouth is for food and water, chewing, talking, but not breathing. It's emergency air. It's like you're on a long trip and you're hungry, kids are starving. Okay, go to McDonald's once a year. But don't make that a habit. All right, habitual breathing through the nose is health food. That's the best air. Once in a while, you got to breathe through the mouth. You're in a hurry. You have to, get away from something. Once in a while. But we are not designed by nature to be mouth breathers. No animal is actually, except some artificially bred dogs like bulldogs who don't really live very long.
Okay.
And they have a lot of respiratory problems because they're mouth breathers.
Well, let me ask you then, if a child does show signs of pediatric obstructive sleep apnea, or I think what's referred to as POSA, what steps are taken to actually diagnose it?
Well, you're right, and I'm actually not making a diagnosis. I'm not a pulmonologist. Diagnosis can be only made by physicians who can read a sleep study. But all the signs are there. I mean, if it looks like apnea, it's usually apnea. And although I don't diagnose, I pretty much, when I send them for sleep studies, and I'm actually I'm a dental consultant at Lurie Children's Hospital, where our sleep lab is in the Department of Pulmonary Medicine. And I refer directly because I've been trained in sleep medicine assessment for children at St. Louis University's Medical School. Dr. Stephen Sheldon is a professor, and he took a handful of dentists from Chicago and trained us in this. And he's going to be training lots of others because we've found a lot of kids who are at risk, got them the sleep studies to confirm it, and we're fixing a lot of them without surgery. The other thing that's really important, because you mentioned teachers, you mentioned parents, how in the world could a teacher communicate that their child might be at risk for sleep apnea and possibly ADD?
Sure.
Well, on that note, we've recently been invited by the dean of the nursing school at the University of Illinois in Chicago to propose and develop a study by which nurses who are coming to the University of Illinois to get certificates in school nursing, is that we work with them to help develop a protocol by which they can work with teachers and teachers' aides to recognize we're going to train the teachers and teachers' aides how to recognize behavioral and physical risk indicators of sleep apnea. The teacher, after training, will identify certain kids that they think are at risk. They will get that list to the nurse, who's already screening kids for eye problems and speech problems. And most school nurses have some basic training in sleep assessment. We're just going to give a little bit more information to them based on our research. And then the teachers and teachers' aides can get the kid for the school nurse to confirm what the teacher thinks that they're seeing. And if it checks out based upon scientific evidence, the nurse can't diagnose either, but she can make the final assessment and make sure that the parent is informed that at school, just like they would for eye problems or speech problems or hearing problems, that their child has been deemed as possibly being at risk for sleep apnea, and then give a list of resources of where to go, which often is the pediatrician, but many pediatricians really haven't been taught about sleep medicine. Sleep medicine is not something routinely taught in pediatric medical residencies, maybe a few lectures, but how to do adequate assessment, especially with craniofacial, jaw risk assessments. This is brand new. We've only recently discovered this stuff. So, but this is there's a lot of work being done. We really want to get in something like this interview is hopefully going to help get some of this stuff noticed and get more kids out.
Let's say that a parent or a teacher or a caregiver thinks that there may be a possible problem, and if it's diagnosed that there is a problem, what are some of the ways that it's treated?
Well, for one thing, if a child has extremely enlarged tonsils or adenoids, that again, that's tissue designed to fight infection, And in many cases, if not the majority, it has to do with some degree of mouth breathing. There are other reasons. There could be food allergies that make tonsils and adenoids get big, environmental allergies. I mean, we haven't really teased that out, but there's a lot of evidence to support that kids who are breastfed, for a prolonged period, tend to be less susceptible to these things. Well, it's not just the quality of the milk, but it's actually the actual physical work that a baby has to do to extract the milk from the breast, combined with superior quality of breast milk over cow's milk-based formulas, is protective against a lot of problems. One of them is crooked teeth. The jaws and teeth, when they don't line up, that's called malocclusion. Well, we're finding that certain major components of malocclusion are independent risk factors for impaired breathing. So sometimes the treatment, if they don't need their tonsils or adenoids out, or don't get them out, or the decision hasn't been made, we start changing the architecture of the jaw in the airway. Some of these kids don't even need it. The other thing is, tonsils and adenoid surgery is got a pretty poor performance in terms of being long-term effective at improving airway. It can rescue a kid out of immediate danger and get them breathing better, and that's a good thing, especially early in life during growth and development of the brain. But in turn, it doesn't really cure every kid. In fact, some kids don't respond at all to it. So what do? Well, we're suggesting that if we can change that architecture by making the jaw wider and pulling the jaws away from the throat, kids who get tonsils and adenoid surgery hypothetically will do better long term. We don't know that, and some of these kids, maybe this will totally preclude that. There's also medically treating it with steroids and drugs. And everybody knows, one of the symptoms of sleep disordered breathing and apnea is ADD and neurological development, cognitive impairments, ability to pay attention, ability to learn. I mean, when a kid is sleeping through the night and cycling through all the stages of sleep and spending increasing amounts of time in rapid eye movement sleep, REM sleep, that's when learning takes place. I mean, that's when you consolidate memories and learning. You repair during sleep. You replenish damage that's done while you're awake. And we know what happens if kids have attention deficit disorder. They prescribe them, and they get kids addicted to amphetamines, speed. Ritalin, Adderall, right. That's speed.
Right.
So we'd like to preclude that when we can.
Dr. Boyd, you have given us a lot of great information about pediatric sleep apnea. I'd like to thank you for being on this interview and sharing all of that information.
Let me have two more things to tell you.
Sure.
Childhood obesity, appetite regulation, poor sleep. Kids are hungrier. They're hungry for calories. This is where they're finding brand new research shows that the childhood obesity epidemic is probably a symptom of sleep deprivation. And Finding Connor Deegan, it's on YouTube. Finding CONNOR Finding Connor Deegan. Watch it. It's very, very telling.
All right, fantastic. That's, again, great information for our viewers. Thank you so much.
Thank you.
Again, my name is Michael Grady. This has been another episode of Local Expert Interviews. We've been speaking to Dr. Kevin Boyd of Dentistry for Children and Families about pediatric sleep apnea. If any of our viewers would like to get more information about pediatric sleep apnea from Dr. Boyd, please refer to the phone number at the end of this video. Again, Dr. Boyd, thank you so much for this interview.
Thanks for the opportunity, Michael. This could help a lot of kids. I'm not trying to drum up business for myself. I want people to be aware of this.
I agree. Again, thank you, sir.